everyone. Thanks for joining today's webinar, Virginia Clinicians for Climate Action's 2020 webinar series, Health in Virginia's Changing Climate. This is our 8th webinar this year, and we're really excited today to be covering a topic and a new report that we've just put out in the last couple of weeks on transportation emissions in Virginia. Just a couple of logistical announcements. One is that everyone is in listen-only mode and will be throughout this presentation. If you have a question at any point for Dr. Harris, who will be giving our presentation, please enter those in the Q&A box that should be on your Zoom menu there. We prefer to take questions that way rather than through chat, but we'll certainly try to monitor both. And we will end promptly at 1:30 today. We'll have about 10 minutes at the very end of the presentation for audience questions. So please do just put those in as you think of them throughout the presentation. And with that, I'll turn it over to VCCA's chair, Dr. Samantha Adu. Sam.
Well, thank you, John, and thank you all so much for joining us today for VCCA's 8th installment in our Health in Virginia's Changing Climate webinar series. And I am delighted to present our speaker today, Dr. Drew Harris. Dr. Harris is an assistant professor of medicine in the Division of Pulmonary and Critical Care at the University of Virginia. He completed his undergraduate degree at Emory and medical school at the University of Pittsburgh, followed by an internal medicine residency and chief residency at Emory University. After residency, he worked in the Indian Health Service on a Navajo reservation in northern Arizona for 2 years. He completed his pulmonary and critical care fellowship training at Yale University in 2017 and has been working at UVA since then. Dr. Harris is focused on improving care in vulnerable populations through clinical practice, research, and medical education. His disparities-focused implementation research has been funded by the NIH, Health Resources and Services Administration, Robert Wood Johnson Foundation, and others. As an associate program director of the UVA Internal Medicine Residency Program, he created a community-partnered medicine program that focuses on community-based clinical care, community service, and advocacy training. He has several clinical areas of expertise, serving as medical director of the Adult Asthma Program at UVA and medical director of the largest federally funded Black lung clinic in the nation in Southwest Virginia. And during the COVID pandemic, he's been leading the UVA Health System's efforts to support post-acute and long-term care facility outbreaks. Outside of work, he prefers spending his time outdoors with his wife and 2 boys. So please join me in welcoming Dr. Harris.
Thanks for that introduction. Let me see if I can share my screen here. Maybe. There we go. All right, well, I'm pleased to be with y'all today, and I'm going to cover a pretty broad range of topics here, mostly focused on why particulate matter matters. I have no disclosures. I have 3 main objectives. The first is to introduce particulate matter, specifically PM2.5, and talk about health impacts, and then talk about health disparities related to PM2.5, and then finally finish talking about how transportation emissions contribute to PM2.5, and talk some about the transportation report that VCCA put out a week or so ago. So with that, I think this particular photo from the EPA has been in every single air pollution talk I've ever seen. This shows what particulate matter is in relation to the size of human hair and a grain of sand. And so particulate matter typically has 2 different sizes that we often talk about, which is coarse particles, which is about 10 micrometers in diameter, and PM2.5, which is 2.5 micrometers in diameter. And you can see about 5 PM10 molecules or particles will comprise 1 human hair, and closer to 20 or 30 for PM2.5 for human hair. And we'll talk about why the size matters in a moment. I wanted to talk a little bit about where particulate matter comes from. And these are familiar sources to you, I'm sure. Largely it's from combustion of things like in power plants or burning wood. Also, we see forest fires or transportation related from unpaved roads and agriculture. We see lots of agricultural dust, and this is sort of the primary mode of particulate matter formation in our environment. There also is a secondary formation or an indirect formation, which includes air pollution that has complex chemical reactions that occur up high in the environment to create additional particulate matter. The size of the particles matters because the larger the particles are, the more likely they are to get stuck in the upper airways in the extra thoracic space. The smaller, finer particles are more likely to get deeper down into your lungs, and that becomes relevant when we talk about what types of diseases and problems these particles cause. So the toxicity of particulate matter varies depending on the composition, size, as well as the duration of exposure. And I wanted to show you a little bit about how particulate matter is different depending on where you live and what are the sources of the particulate matter themselves. And so this graph shows the difference in particulate matter composition between two different sites in Virginia. The one in the southwest tip of the state is in Bristol, and you can see higher amounts of sulfate in Bristol, and this is likely from coal-fired power plants. And in Richmond, you can see on the right, the Richmond area, you see higher amounts of organic carbon, which you could think of as soot. And so there's a lot recently written in the last year or so about how we should think differently about particulate matter, in that some particulate matter is probably more toxic than others depending on its composition, but I think an area we're still all learning more about. So when you breathe in these particulates, what happens? And I'll start with the figure on the left. And this shows the schematic of the airways and alveoli in the lungs. And so most of the particulate matter that you inhale will get kicked back out of the lungs through what's called the mucociliary elevator. So you have little cilia that line the epithelial cells of your airways, and they sort of beat in a coordinated fashion and kick out the particles up, lined by a surface of mucus as well. If the particles make it deeper down into the lungs, what can happen is that the amount of particles overwhelm the resident cells that are in the lungs, which are macrophages. And if you overwhelm the macrophages, then the smaller particles can get absorbed, can cause direct inflammation and oxidative stress, and cause a whole slew of downstream inflammatory pathways in the lungs that lead to things like asthma or asthma exacerbations or COPD exacerbations. And the other schematic shows what happens from a more systemic or cardiovascular standpoint, which is once these small particles get into the pulmonary and then systemic circulation, they cause a more system-wide or systematic oxidative stress and inflammatory process, endothelial cell dysfunction, platelet aggregation, vasoconstriction, a whole slew of autonomic nervous system problems that can lead to cardiovascular effects, things like heart attacks or atrial fibrillation and that sort of thing. It's much more than just cardio and pulmonary involvement that particulate matter leads to disease in, and we also see things like neurologic problems, which aren't pictured here but are equally important. And I think important takeaway message is that these particulates, especially these smaller particulates, PM2.5, kill people. They are the largest environmental risk factor for premature mortality across the world. And this map shows sort of the order of magnitude that particulate matter causes in relation to premature mortality. And you can see in the legend for this figure that we're talking about millions of deaths, premature deaths each year, just directly related to particulate matter. And in the US, we're talking about hundreds of thousands of deaths caused by particulate matter. So a major source of problem for us. This graph shows that particulate matter causes more premature deaths, more so than other really common risk factors for death. So things like alcohol use or a high sodium diet or physical inactivity or workplace injuries are all sort of dwarfed in comparison to the amount of deaths that ambient particulate matter causes. And this is a statement directly from the EPA, which shows, again, that numerous studies have showed that particulate matter exposure causes a variety of problems: premature deaths, heart and lung disease, heart attacks, irregular heartbeats, asthma, decreased lung function, increased respiratory symptoms. There are countless studies that show that this is the case. And I'm showing you this, which is directly from the EPA, for a reason, because towards the end of this talk, I will show you a video about someone who is working within the EPA who might actually feel a little bit differently than this. So there are both short and long-term exposure risks, and we usually measure short-term risks by how often people get hospitalized after exposures, or if their asthma flares, or if their lung function worsens, or if they miss work. From a long-term exposure risk, we see new asthma or worse lung function trajectory or lung function growth in kids. And we also see the impact on kids through low birth weight babies or premature births with cognitive problems. We see lung cancers, things that take a little bit longer to develop. So that was sort of a quick flyby overview of the health impacts of particulate matter, especially PM2.5. And I wanted to speak next to about how particulate matter disproportionately affects vulnerable populations. And this study came out about a year or so ago, and it talks about how the burden of air pollution is not evenly shared in all populations. And specifically, they said that white populations experience a pollution advantage. And what these authors meant was that they produce, they are exposed to 17% less air pollution than is caused by their consumption. Whereas people of color experience a pollution burden, meaning they experience an excess of exposure relative to their consumption. You can see that graphically on the figure A at the bottom of this graph. There are lots of studies that have looked at disproportional exposure levels. This particular study looked at the Department of Agriculture's schematic for how to qualify communities based on whether they are rural or urban or suburban, and whether they're in a high commuting area like a suburb or not. And they looked at communities stratified by both race and ethnicity, as well as by socioeconomic data. And they specifically were looking at which communities lived in areas where there were facilities that were polluting through, such as things like a power plant. And they also looked at how much each of these facilities were polluting, and they could then calculate the quantity of particulate matter exposure that these communities faced. And you can see differences in the amount of burden of pollution in all of these rural, urban, suburban communities, but especially in the urban areas, that Black and brown and poor communities have a disproportionate exposure to higher amounts of particulate matter compared to white and richer communities. So I think this is, a second example of many, many, many papers that show a disproportionate burden of pollution exposure, and specifically particulate matter exposure, in racial minority communities and in poorer communities. And the reasons why this is the case is complex and probably beyond the scope of this talk, but it involves things like systemic racist housing policies and having less political influence and less influence about where specific power plants or other polluting facilities are actually placed, factories, industries, in relation to specific neighborhoods and where people are living. So I chose to focus on how this disproportionate burden of particulate matter exposure impacts health by focusing on coronavirus, because I think I'd be hard pressed to not try to link this important environmental topic in the middle of a pandemic to the virus itself. And so this first paper that I'm reviewing here shows at the bottom a graph of where the yearly average particulate matter levels are highest in 3 different states. And you can see that these authors correlated these levels of high particulate matter exposure to higher rates of COVID mortality, which you see on the graph at the bottom right. And these authors speak to how that air pollution is likely one of several very important factors about why Black, brown, and poor communities in these specific neighborhoods are experiencing higher COVID mortality. And so there are lots of other factors to think about. The poor racial minority communities are living in worse housing conditions and more crowded homes with multi-generational living. They often don't have the luxury of working from home. They work essential low-paying jobs where they have to show up to work each day. they rely on public transportation, they don't have access to care, lots of reasons. Not to say air pollution is the only factor at play, but certainly air pollution is an important factor at play. And we know this because we know that things like particulate matter that have a higher burden of exposure in disadvantaged communities can cause things like chronic respiratory and chronic cardiac disease. And we know that respiratory and cardiac comorbidities are critically important when we think about people's risk for COVID severity and COVID deaths. And so if racial minority and poor communities are experiencing higher pollution burdens and they have higher comorbidity rates, that they're more likely to have more severe and more deaths from coronavirus because of these comorbidities. And there are lots of other studies prior to this pandemic that show that the higher exposure of particulate matter has been linked to worse outcomes in other infections. And so previous pandemics like SARS and previous other viral infections like the flu or even simple bacterial pneumonias, those who are living in higher particulate matter burdened areas have worse outcomes in these settings. So the next COVID-19 study I wanted to talk about was this, and this is a nationwide survey that came out a couple of months ago. It looked across the country at thousands of US counties, and they used a model that accounted for lots of different variables related to demographics and socioeconomics and case positivity rates and the ability to socially distance, a whole slew of variables factoring into this model. And they showed that throughout these 3,000 counties, that tiny increases in long-term particulate matter exposure, so we're talking 1 microgram per meter cubed, was associated with significant 8% increase in COVID-19 mortality rates. And these authors stratified these counties by those that lived in areas with particulate matter either above or below a threshold they chose at 8 micrograms per meters cubed. And you can see those who are living in the higher amounts of particulate matter, so 8 plus, were 13% Black, whereas those living in less polluted areas with particulate matter less than 8 or less, or significantly less, 1% of those communities had Black, 1% of those residents were Black. So again, disproportionate burden of exposure, with the exposure causing a much higher increase in COVID mortality rates. So what are we going to do about this disparity of exposure and the particulate matter problem in general? And this has been a problem for a century, and the Clean Air Act, which was passed in 1970 and subsequently amended many times, has been sort of the backbone at trying to reduce air pollution in our country. And this Clean Air Act was responsible for getting the EPA to set the national air quality standard. And they've done this for lots of different pollutants, including particulate matter. You can see at the chart on the bottom that there's a standard for exposure limits for both long-term and short-term levels. And the EPA has the power to enforce this standard with most specifically fines to help keep people in check in various states. And the EPA is charged to carry out reviews of existing evidence to figure out if these standards are appropriate or if they should be modified. And they've been modified several times throughout the 50 years that this Clean Air Act has been passed. And the EPA appoints a Clean Air Scientific Advisory Committee, or CASAC, which has 7 members. And every 5 years or so, they review each of these pollutants and decide if additional regulation changes need to be made or additional changes to the standards need to be made. And there's so much data to review that the CASAC, this committee, has actually in the past, up until this administration, required help from a larger panel of experts. And so they have expert panels for all the different important pollutants, particulate matter being one of them. And there was, prior to this administration, a 20-member particulate matter panel that helped advise this CASAC, this committee, to help decide what to do about changing these standards. And we'll come back to why that's relevant in a second. But since this Clean Air Act was passed in 1970, you can see that our economy has grown tremendously, and the amount of vehicle traffic has grown tremendously since that time. Our energy consumption has increased, but the success of this act is that our air pollution has actually improved significantly because of this Clean Air Act. So I think it's widely considered one of the most effective public health policies of all time in the US. And Dr. Colmer is on this webinar with us today. He's a colleague of mine at UVA who recently published this paper in the journal Science a couple of months ago that shows the effectiveness of the Clean Air Act, which you can see the particulate matter concentration throughout the US has declined dramatically over the last 30, 40 years or so. We also can see data regionally. This is southeastern US from the EPA, which shows even in the last 15, 20 years or so that particulate matter concentrations have continued to decrease and we're largely below the national standard in the southeast part of the US. So the Clean Air Act has been successful at reducing air pollution levels. There are huge health benefits to this reduction in air pollution, including particulate matter, with hundreds of thousands of particulate matter attributable deaths avoided each year. And the monetized health benefits are significant. So they're much greater than the costs by a ratio of 32 to 1. And by some estimates, there are over $2 trillion of monetized health benefits related to this. So huge amounts of lives saved and monetized health benefits as well. So you could hear me say all of that and feel great about what we've done with the EPA and the Clean Air Act with sort of great success at reducing air pollution, including particulate matter, and have a moment sort of like George Bush did in 2003 when he was 6 weeks into the Iraq War with the mission accomplished banner behind him, which in retrospect we now realize was only the beginning of this conflict. And I think I'm thinking of the Clean Air Act and all these great statistics that show improvement as sort of this moment too. We've done great, but we certainly have a lot more work to do. And this again is Dr. Colmer's paper from Science, my colleague at UVA. And the important finding that I think was found in his paper was that although we've made great strides in air pollution, we have yet to address the disparities of exposures between communities. And so if we start off just looking at the graph at the bottom left, we see on the x-axis, it's PM2.5 rank in 1981. And on the y-axis, it's rank in 2016. And what this graph shows is basically a perfectly straight line at a 45-degree angle, which shows that if you lived in a city or a community that had the worst PM2.5 levels in 1981, you continued to live in the worst polluted, highest PM2.5 level in 2016. So the dirtiest, most air polluted cities back then are still the dirtiest, most air polluted cities now. The cleanest back then are still the cleanest now. And the graph on the right shows that this is broken down into Virgintile. So Jonathan, I'm guessing you took Latin in high school if you use the term Virgintile, which means groups of 20. But you can see rankings in groups of 20, each group ranging from the lowest level of PM2.5 at baseline to the highest, all have about the same average % change in particulate matter. So although everyone's getting a little bit better, we still have disparities in who's seeing the most and who's seeing the least amount of particulate matter, and this hasn't changed in 40 or 50 years. When we think specifically about Virginia, you can see on the left the year 2000 and the right the year 2018. You can see red dots on the graph on the left, which corresponds to particulate matter levels between 12 and 35 annual concentrations. So this is micrograms per meters cubed again. And on the right, we see blue dots, which are levels that are lower, 6 to 12. And so, yes, this is good. In 18 years, we have made significant strides at reduction in particulate matter levels throughout the state of Virginia. But this paper that came out in the New England Journal should make us all have a little bit of pause about not being too smug or feeling too proud of our accomplishments just yet. And this study that came out in the New England Journal was one of over 600 cities that looked at short-term or daily PM2.5 concentration levels. And if you look at the figure here, on the x-axis, we see PM2.5 concentration. What I want you to notice is the slope of this line, which is steeper as you get to lower and lower numbers of PM2.5 concentrations. And this change in slope means that for lower levels of PM2.5, each change in PM2.5 concentration leads to a much more dramatic difference in mortality. So what that means is that when you reach a lower level of PM2.5 concentrations, you can impact mortality even more with lower or higher with changes in PM2.5 levels. So just because in Virginia we have relatively lower levels, if we could reduce these levels even more, we'd have an even greater impact on mortality. Hopefully that made sense. So with that in mind, I wanted to next talk about this New England Journal article, which came out, I think, a month or two ago. And this was written by what was called the Independent Particulate Matter Review Panel. And this was the group of people who previously were advising the EPA on what to do with particulate matter, but the current administration got rid of these advisory panels, which I mentioned a few slides ago. And so we're left to the Clean Air Scientific Advisory Committee, which is a group of just 7 people making recommendations on their own without the support of what usually were a big panel of experts to help them figure out what the appropriate standard should be. So this panel no longer works for the EPA, they're independent, but they reviewed all the literature and said that the current PM2.5 standards are insufficient to protect public health. There's no evidence for a PM2.5 concentration threshold for health, meaning even if you get to a low number, it doesn't necessarily mean it's healthy. And there's a continuum of adverse effects which decreases as the standard decreases, meaning the lower the standard, the less adverse effects you're likely to see. And they made a recommendation to reduce the PM2.5 annual standard down to 8 for long-term exposure and to 25 for short-term exposure. And with this in mind, I wanted to introduce you to, let's see if this video worked, to a Dr. Tony Cox, who is the current chair of the Clean Air Scientific Advisory Committee. And we'll talk about why this recommendation from the New England Journal is not likely to be followed.
The most important scientific fact for us today is that decades of reduction in ozone levels have not produced the predicted health benefit.
But what he's describing about there not being any benefit is not a mainstream view, right? That there is a strong consensus among people who actually take care of sick patients with asthma and other lung diseases that ozone is harmful, it causes illnesses, it causes them to die. It's in our guidelines to tell people to avoid the outside when there's high ozone days. It's not made up stuff. This is based on science. So I just want to clarify that as well. So this isn't really something that in 2015 we should be talking about whether ozone affects human health. We're way beyond that.
So I'll take any opportunity to put a Dr. Dre song into a PowerPoint presentation I'm giving, but hopefully you get the sense that Dr. Tony Cox has views that don't fall in line with what the rest of environmental scientists and physicians and clinicians believe about air pollution specifically in that testimony related to ozone. But he has said several things even related to particulate matter that I think are concerning. And so again, he's the current chair for the KSAC committee. He's been funded by both Philip Morris and the American Petroleum Institute. At one point, he was funded by Petroleum to write a paper. In that paper, he wrote that particulate matter doesn't lead to premature death, which hopefully at this point in the presentation, you agree that there's an abundance of data to say that is the case. And Dr. Cox is a smart guy. He just doesn't believe that any epidemiologic study should be included in the analysis of PM risk. So any observational study that we've used to come up with this evidence, he doesn't think should be included. And so because of this, which is not in line with mainstream sort of environmental science and medicine, the committee has not recommended not changing the current PM2.5 standard, and their final rule should come out pretty shortly. So I'm guessing that some of you are wondering, what would Joe do at this point as he takes over a new administration and the new EPA in 2021? And I don't know what he's going to do, and none of us do, but I think he has to balance the pursuit of a healthier PM2.5 standard versus respect for the process and precedent that exists around us. And so for 50 years, the EPA and the Clean Air Act has done great things to reduce environmental pollutants in our country. And I think not blowing up this whole process is potentially important, and maybe more important than revoking the current standard immediately as soon as President-elect Biden takes office. So just to give you some ideas of what usually happens is that the current standards are reviewed about every 5 years. The reviews take about 3 years to complete, which is why they occur every 5 years or so. And the precedent is that the current Clean Air Scientific Advisory Committee would be the same for the next couple of years during Biden's administration. And what happened in the last administration is that there's been some changes to the current EPA policies, including that you can't serve on this Clean Air Scientific Advisory Committee if you're funded by the EPA, which excludes a lot of academic researchers and scientists and environmental scientists. But you can serve on the committee if you're funded by industry. And so the current EPA prioritized geographic diversity and took away those who are funded by the EPA. And as I mentioned, they disbanded these advisory panels. So these groups of 10, 20, 30 people that help the CASAC folks decide what the appropriate standard should be. So I'm not sure what President Biden will do in the next administration. He might revoke the current PM2.5 standard based on the evidence that we just talked about. I'm not sure if he'll have the same team review the same data, which is potentially something he could do. He might remove the current CASAC. He might put more academic scientists back on CASAC. He might reestablish advisory panels. I think these are all things we should be keeping our eyes on as we approach 2021 and moving forward with the next administration. So I am not an economist, and Dr. Comer, I would love your input on this maybe after the talk if I say this wrong, but there are certainly counter arguments for maintaining the current standard for particulate matter. And this is a marginal cost abatement curve. And so I'm going to try to walk you through this. And the curve I want you to focus mostly on here is the one that's sort of L-shaped here, that starts off high on the left and moves down low to the right. And on the x-axis here is the level of pollution. And as you move further to the left on this lower curve here, you're abating pollution at reasonably low cost. So in a very high pollution area, when you get rid of some pollution, it's pretty cheap to do so initially. But as you gradually improve your pollution levels, it becomes increasingly expensive to make those changes. And so in theory, it's possible that we're somewhere on this rising slope of this curve, whereas if we were to enact more strict pollution abatement measures, like a stricter standard, the societal costs might be cost prohibitive there. The other aspect of this curve is the marginal benefits of pollution abatement. So if we start off in a very high pollution area and we are cutting pollution, we'll see lots of marginal benefits. And as we get less and less polluted, we see less and less benefits, potentially health benefits here. I think this curve probably is less applicable to us for a couple reasons, mostly because we saw that even at very low levels of particulate matter, small changes in particulate matter leads to big changes in mortality, that steeper slope in the New England Journal article. And so I think this sort of assumption in economic theory probably doesn't hold up as well. But I think the cost curve is something that we should think about in that it might be overly costly, meaning that for the deaths we avoid or the asthma exacerbations we avoid by reducing pollution further, perhaps it's even more and more expensive to do so as our pollution levels get lower. And there's sort of an age-old argument of debating whether we should be supporting things for our economy and jobs versus saving our environment. And I think it's sort of popularized as you either have one or the other. And I think the reality is it's much more nuanced, and you can't have a healthy economy without a healthy environment. And so I think certainly there are counter arguments for maintaining the current standard, but I would be in favor of organizations like the American Thoracic Society and this independent review panel for particulate matter, which all favor a further reduction in the particulate matter standard. So final objective here is to talk about particulate matter as it relates to transportation emissions and talk about some transportation policy as well. So this is again a graph from the EPA that shows where the particulate matter comes from in the US. And when we talk about transportation, It's largely the green and purple, the highway and non-road mobile vehicles here. But they're also important for us to recognize is some component of stationary fuel combustion that is contributing to particulate matter in transportation. And for that, we should think about electric vehicles. When we're charging our batteries, we're pulling electricity from a power plant somewhere. And in Virginia, you might be pulling power from a Dominion power plant in St. Charles, Virginia, and Southwest Virginia, which is a hybrid plant that uses some coal to burn, and you might be contributing to worse air pollution in Southwest Virginia by driving an electric vehicle in Charlottesville or in Northern Virginia, where our power is coming from, Southwest Virginia. In Virginia, transportation accounts for a huge percentage of Virginia's carbon dioxide pollution, I think this is what prompted the Virginia Clinicians for Climate Action to develop this transportation report, which I'm going to go through in the next 10 minutes or so in a little bit of detail here. And the first slide I want to show you is all the particulate matter in the state of Virginia. And so this is the graph. The darker the color shows the more particulate matter exposure. We see darker colors in Northern Virginia and around Richmond and Norfolk and Southwest Virginia. And you can see our levels average around 6 to 9 throughout the state. And the health impacts here are substantial, with 3,000 premature deaths each year, over 200,000 asthma attacks, hundreds of strokes, 300,000 lost work days, $23 billion in adverse health costs annually directly related to particulate matter in our state. When we think specifically about transportation, we see a similar colored graph here, but much lower particulate matter contributions here. And so this is about 5 to 10% of all the particulate matter in Virginia, which still is substantial when we talk about even small changes in particulate matter are important for health outcomes. And so we see 5 to 10% of the particulate matter here, but also about 5 to 10% of the adverse health effects. So we see almost 200 deaths, 150 heart attacks, 5,000 asthma attacks, 20,000 lost work days, and still on the order of $1 billion of financial costs associated with this related to transportation. Some of the transportation particulate matter in our state is driven by our neighboring states. So we're pretty close to Washington, D.C. and in places like Johnson City and Southwest Virginia. And so some of the particulate matter comes from out of state. Our transportation policies really can only influence what happens inside of our state. So if we look specifically at Virginia transportation inside of our state, we see an even smaller percentage here, but still nearly 100 deaths, nearly 70 or more than 70 heart attacks, thousands of asthma attacks, 10,000 lost work days, and almost $1 billion still in costs related to these health outcomes. Our transportation report talked some about disparities. We use the social vulnerability index from the CDC, which factors into a whole bunch of variables, including socioeconomics and race and ethnicity and housing. You can see the vulnerability index for our state is stratified into 5 groups, ranging from the least to most vulnerable. And you can see the most vulnerable populations experienced 61% higher death rates in Virginia due to particulate matter exposure. And so we talked a lot about disparities throughout the country related to particulate matter, and our state's no exception here. Children in Virginia bear the burden of air pollution and specifically particulate matter in Virginia. You can see some of the statistics here. Particulate matter leads annually to 7,000 cases of new asthma in kids and 230,000 asthma attacks in kids, 120,000 cases of bronchitis and respiratory symptoms, slightly lower numbers for Virginia-specific particulate matter, but still a major problem in kids throughout our state. And Virginia's made a lot of progress to cleaner energy and cleaner air in 2020. The first thing that happened was passing the Clean Economy Act, which mandates 100% renewable energy by 2050, gets rid of almost all coal-fired power plants by 2024, with the exception of the Dominion plant in St. Paul, and has developed specific programs for disadvantaged communities. And so they focus on energy efficiency in low-income communities. Some of the power companies are mandated to hire from low-income communities and help people get job trained to be able to work effectively in these organizations. Virginia also joined the Regional Greenhouse Gas Initiative, which has lots of mid-Atlantic and northeastern states along with it. This is a cap and trade system. It caps carbon dioxide emissions. Power companies have to either reduce their pollution to meet these caps or they have to buy additional allowances through RGGI, through this greenhouse gas initiative. And so the money that goes towards this cap and trade system will then benefit low-income communities for energy efficiency. There's also money allocated to protect the Virginia coast. And the last thing that we've done in Virginia is give thought to adopting a section of the Clean Air Act that is focused on adopting vehicle emissions similar to what is done in California. And so a brief history here. When the Clean Air Act was passed in 1970, California had their own vehicle emissions regulations already established. And so part of this federal act was that California could maintain their own standard. Other states aren't allowed to create their own standard, but they can adopt California standard, and 13 states and Washington, D.C. have already adopted this new standard. There's multiple components to California's emissions program. One involves low emission vehicles for both greenhouse gases and pollution for new vehicles. And this does things like improve engine and emission controls, use lighter materials, more likely to adopt hybrid technologies, improve miles per gallon in cars. And it's expected to have a huge reduction in greenhouse gases from the year it was enacted to 2025, so 40% reduction. Also important to note that the current federal administration and EPA have revoked the current greenhouse gas emissions part of this waiver. The other aspect of the California program involves zero emission vehicle regulations, which requires automakers to make and sell electric vehicles. The current waiver says that 8% of new vehicle sales in 2025 have to be zero emission vehicles. And once last year, when the federal government revoked this greenhouse gas standard, you might be someone who looked much like this person who posted this on Twitter in response to this greenhouse gas waiver being revoked. It angered a lot of people in California, and this is currently a lawsuit in the U.S. Court of Appeals in Washington, D.C. at the moment. But while we wait for that lawsuit, there are 4 automakers, I think it's Honda, Ford, VW, and BMW, that have agreed to basically continue the same greenhouse gas standard, slightly less restrictively on their own with California. And the current governor of California last month signed an executive order to have 100% zero emission vehicles by 2035. So I have, I think, 2 more slides that both describe the benefits of the low emissions / greenhouse gas emission standard in California if Virginia were to adopt it, and also the zero emission vehicle standard. So if Virginia adopted California's existing standard, we would see a lot of benefit. And so we'd see, this is, if this was adopted by the year 2035, what would happen? We'd reduce 10% of total vehicle greenhouse gas emissions with huge amounts, millions, hundreds of millions of dollars of cost savings. Including, there's some co-benefits here related specifically to air pollution. Air pollution and greenhouse gases share the same emission sources, and so we're gonna see some health co-benefits related to this as well. And the last piece of data I think I'm showing here is if Virginia adopted the zero emissions vehicle program in 2035, we would have 13 billion more electric powered vehicle miles driven than we do now. In this graph at the bottom left, we're comparing business as usual versus zero emission vehicles. You can see we would save lives and have hundreds of less asthma exacerbations if we did this, with $100 million of economic benefits. And so I think this is an important policy component that we should be thinking about. If you haven't read the transportation page for Virginia Clinicians for Climate Action, I would encourage you to do so. There's some good videos with some of my colleagues at UVA on this website. And I'll finish with this slide, which is that particulates matter. That particulate matter comes from many different sources, causes lots of morbidity and premature deaths around the world and in Virginia. That we should think about vulnerable populations who throughout the country face disparate particulate matter exposure and health impacts. The Clean Air Act has been effective overall at reducing PM2.5, but as my colleague Jonathan Colmar at UVA has shown, we have not really been able to reduce exposure disparities in the US. And I think the final point I want to end on is that we as Virginia Clinicians for Climate Action should encourage our governor and our state legislator to opt into the California vehicle emission standard. And I hopefully have convinced you to feel similarly based on the data that we have. And with that, I'll take some questions.
Well, Thanks so much, Drew. Just 1 second before we open it up to questions, just wanted to share a couple of other advocacy opportunities, and please do put your questions in the Q&A box in your Zoom menu there. I see that we have had a few come in, but just to highlight a couple of other advocacy action opportunities we have at VCCA. One is specifically for health professionals. We have designed a call to action which talks about transportation reform and air quality, among other issues, that we are encouraging all health professionals in the state who are supportive of these types of policy reforms to sign on to. You can see that action there on our website. And as Drew mentioned, our transportation page has a lot of resources, including the full report that he covered the main findings of, the transportation videos, and a lot of other external resources that are useful to better understanding this in the upcoming push that we expect to see in the General Assembly next year. We have I should also mention that we have our VCCA Advocacy Day coming up January 19th. Information is on our site under the Advocacy tab, and we would love for you to join us. It's going to be virtual this year, of course, but that'll give everybody an opportunity to speak with your legislators about these policies and our need to improve them. Next, I just wanted to remind everyone that this webinar is available for CME credit. You'll all get a link tomorrow and a follow-up email with detailed instructions, but here are links that you can check out if you'd like to claim CME credit. And with that, we will open it up to questions. Drew, I see that we have a couple in the Q&A box, and we had one that came through via chat for you to check out as well, but I'll turn it back to Drew, and thank you very much.
Great. Let's see if I can answer. I don't know if I can answer all of these, but I will try, and I'll welcome anyone to chime in if people know the answers that I don't. The first is from Susan Miller. She asks, is anyone carrying legislation for adopting the CA vehicle standards? Has League of Conservation Voters adopted this in their advocacy? I don't actually know where we stand in adopting this in Virginia. I actually reached out to my colleague, Gary Ewart at the American Thoracic Society to see if he had thoughts about where I could find that information out, but I don't actually know. I think if anyone knows the answer, that would be great. My strategy would be to reach out to my state legislator and find out, which I haven't done yet, but I welcome anyone's input there.
Drew, I'm happy to weigh in a little bit on this, and thank you for your question, Susan. The League of Conservation Voters is supportive of this advocacy action. It's a top priority for them and many other partner organizations in the environmental space that we have. There has not been a patron identified for this particular policy yet. I think that they're still negotiating the length of session and how many bills each legislator can carry in this next session, but I expect that will be made known at some point in December or early January. But it's all but guaranteed to definitely be introduced as a potential policy in next year's General Assembly.
Great. Let's see. Next question is, I wanted to ask about Virginia's current status regarding air quality monitors. I'm aware of the Virginia Youth Climate Cooperative seeking legislation to have a monitor in each county, which is not the case now. What would you consider optimal monitoring for monitoring purposes, a single monitor per county or more? And I think that also relates to the question that preceded that, which is how granular is your PM2.5 data for Virginia? Does it get down lower than county? I think the more monitoring, the better. Clearly, particulate matter is relevant in local communities, and the more granular the data, the more helpful it is, especially when we know that pollution near the sources of pollutants, like near a power plant or near roads, is higher than elsewhere. And so we probably have hotspots around the sources of pollution like near highways and near things like power plants. And I think if there was a mechanism to improve the monitoring, that definitely, I think that would be great. I think most of the more recent data is based on modeling, which is getting increasingly sophisticated and more accurate. But I think the more actual monitoring we have, the better we'll be able to do there. And John, I don't know if you can better able to answer that first question about how granular the data is. I think it was just based on maybe like something like 8 to 10 sites throughout Virginia. I don't think there were that many. Mostly it was modeling, but I'll defer to you there.
That was a real barrier that we found in commissioning this report. We were really hoping to identify some hotspots related to transportation corridors and be able to detail impacts on local vulnerable populations. But we were not able to drill into that level and therefore had to rely on some of the modeling that's available through EPA tools and other scientific models. So that was a barrier to us being able to get down into highly specific hotspot areas in Virginia, and one that could potentially be improved within improved air quality monitoring to inform future studies.
Thanks. Next question is, how do you have conversations about climate change and health with your patients? So I appreciate that question. And I think this is challenging. So I'm a pulmonologist and I'm an asthma doctor. And so I try to build it into what I do clinically on a day-to-day basis. And so the easiest way for me to build it in is longer pollen seasons triggering worse asthma. And so I will usually focus on that as one of the reasons why their asthma might be worse this year than last year, or worse now than it was 10 years ago, is because of climate change impacting lots of things leading to longer pollen seasons. And I take care of patients from a whole range of geographic and socioeconomic and political spectrums. And I certainly have had patients who don't agree with me on the science of climate change. And I don't typically get very far when I try to engage them in sort of the one-on-ones of climate change. But I think in those who are willing to believe in the science, that I am mostly talking to them about how it impacts them on a day-to-day basis with asthma. Welcome anyone else who has different ways that they approach climate change and talking to patients.
This is Sam. I find it interesting that you say that that's the link that you often use, because I find as a pediatrician, I find that the easiest link myself, talking with my patients about how their allergies and secondary asthma are appearing earlier and lasting longer as a result of later winter and earlier spring. It's pretty intuitive, and most people are seeing it themselves. So it's, and I agree with you. I don't find it very valuable to talk about the science of climate change as much as, try to potentially invoke any discussion on that front, as much as give them information about changes that affect them directly.
Thanks, Sam. So it looks like the next question is, expand on the trend of Black lung disease in Virginia. So I think I'm always happy to talk about Black lung. One of my favorite parts of my job is going to Southwest Virginia to work with Stone Mountain Health Services, which is a Black lung clinic. And Black lung is surging, and it's an epidemic, and there are more and more cases of progressive massive fibrosis, which is the most advanced form of the disease, which is essentially untreatable and usually fatal. And at our clinic, we see something like 200 or 300 new cases of progressive massive fibrosis each year. And so we're at the center of a national epidemic in this particular Black lung clinic. And it's a devastating disease, and these folks are under-resourced, and there's very little subspecialty care and very little access to things like pulmonary rehab and even lung transplantation. And the trend is largely due to inhaling respirable silica with smaller coal seams and equipment that's grinding up the particles even finer. So this is a big topic. I have separate talks related just to black lung, but I think it's a concerning trend for sure in our state. And it involves multiple parts of other states, including southern West Virginia and eastern Kentucky, for sure. Let's see. What is crustal source of particulate matter? Is that what's created by earth moving construction such as large buildings, facilities, roads, or pipelines? I do not know. If that was in one of my slides, I did not look at it in enough detail. But if anyone knows what crustal is, if not, I can get back to Sheila Stone and tell you what that is after I read about it more. So Margie Toman asks, what types of policies would be most impactful for rural Virginia, where the burden of transportation emission seems to be less based on the maps, but the burden of PM2.5 is high? Yeah, so thank you for that question. I think there was very little transportation related particulate matter from Southwest Virginia, but still high amounts. And I think a lot of that is probably from coal-fired plants. And I know, even schools in Southwest Virginia are using coal to heat their schools. And I think there's a lot more coal burning than elsewhere in the state. And so I would be interested to see what happens when, as part of this Clean Economy Act, most of the coal power plants are going to be no longer in existence. And I would like to see the trend that happens there. But I think focusing on power plants would be critical. And I know that one exception for this Clean Economy Act in Virginia was a coal plant that's in St. Paul. And so I don't know I think we talked some about the balance of economic benefits and jobs versus the environment. And I think that particular power plant in Southwest Virginia is a major source of employment and a major boost to the economy. And so I don't think I feel qualified enough to say that plant shouldn't exist anymore, but I'd be interested to see, at least as the rest of the state transitions away from coal, what happens to particulate matters in Southwest Virginia. Should asthma hotspots in Virginia require vehicle emission testing is the next question. I don't know if there's data to suggest that vehicle emission testing would do anything other than make us aware of the problem, but I guess that would be step one, recognizing how much the emissions are contributing in these particular regions and trying to get the old cars off the road that aren't up to speed with current tailpipe emission regulations. And so I would like to see that studied, or I would like to first at least look to see if there has been a study on that. If there is, I haven't seen it yet. And if not, that seems like it would be a great project to do. Obviously, it would require a lot of coordination with a lot of people to get that running, but I don't know any data to show that.
Well, thank you so much, Dr. Harris. I know that we are at time here, so I'll invite Dr. Adut back on to close us out.
Well, Dr. Harris, thank you so much. That was such an interesting presentation. I know I learned a lot, and I feel better informed and more motivated than ever to advocate for transportation reform in Virginia. So thank you again, and thank you to our participants for joining us today, and look forward to working with you all in the months to come and in 2021. Thank you, Dr. Harris. Bye, everyone.